Question 1. A 45-year-old construction worker presents with insidious onset of pain and numbness in the radial 3.5 digits, worse at night. Phelan's test and Tinel's sign at the wrist are positive. Which of the following is the most appropriate initial conservative intervention? A. Surgical decompression of the median nerve. B. Nighttime wrist cock-up splinting with the wrist in neutral. C. Ice massage to the volar forearm. D. Progressive strengthening exercises for wrist extensors. Answer: B. Nighttime wrist cock-up splinting with the wrist in neutral. This question addresses conservative management for carpal tunnel syndrome, indicated by symptoms like radial 3.5 digit pain/numbness, nocturnal exacerbation, and positive Phelan/Tinel signs. The keyword initial conservative intervention guides you to non-surgical approaches. A nighttime wrist cock-up splint in neutral position effectively reduces pressure on the median nerve by preventing wrist flexion or extension during sleep, which are positions that can compress the nerve. For instance, a patient might wear a custom or prefabricated splint while sleeping to maintain this position, alleviating nocturnal symptoms and promoting nerve recovery. Always remember that conservative interventions, like splinting in neutral, are typically the first line of treatment for carpal tunnel syndrome before considering more invasive options. Question 2. A patient sustained a zone V extensor tendon laceration and underwent primary repair. What is the most appropriate initial range of motion protocol to protect the repair? A. Immediate active range of motion. B. Passive range of motion only. C. Immobilization in full extension. D. Early active motion protocols such as the modified Duran or relative motion splinting. Answer: D. Early active motion protocols such as the modified Duran or relative motion splinting. This question centers on postoperative management of extensor tendon repairs, particularly in zone V, and the goal is to protect the repair while facilitating tendon gliding. The key phrase, most appropriate initial range of motion protocol, points to current best practices. While full immobilization protects the repair, it also leads to significant stiffness and adhesions. Early active motion protocols, such as the modified Duran or relative motion splinting, are designed to allow controlled tendon excursion and promote healing while minimizing adhesion formation and improving outcomes. For example, a patient might wear a splint that places the MCP joints in extension while allowing controlled flexion of the PIP and dip joints, or utilize a relative motion splint to promote isolated tendon glide. These controlled motion programs are crucial for optimizing recovery and preventing post-surgical complications like tendon adherence. Question 3. A client presents with pain and swelling at the base of the thumb, particularly with pinching and gripping activities. Finkelstein's test is positive. Which of the following is the most likely diagnosis? A. Flexor tenosynovitis. B. Extensor pollicis longus rupture. C. De Quervain's tenosynovitis. D. Scaphoid fracture. Answer: C. De Quervain's tenosynovitis. This question tests your ability to identify de Quervain's tenosynovitis based on classic symptoms. The key clues are pain and swelling at the base of the thumb, particularly with pinching and gripping, which localize the issue, and Finkelstein's test is positive, a pathognomonic sign for this condition. De Quervain's tenosynovitis involves inflammation of the abductor pollicis longus, APL, and extensor pollicis brevis, EPB, tendons within the first dorsal compartment of the wrist, leading to pain with thumb and wrist movements. For instance, a new parent repeatedly lifting an infant might develop this condition due to repetitive thumb abduction and ulnar deviation. When you see thumb base pain aggravated by pinch and a positive Finkelstein's test, think de Quervain's. Question 4. A client presents with a boutonniere deformity, characterized by a PIP joint flexion contracture and dip joint hyperextension. What is the primary focus of conservative splinting intervention for this deformity? A. Immobilize the PIP joint in flexion and dip in extension. B. Immobilize the dip joint in flexion and PIP in extension. C. Maintain PIP joint extension while allowing full active dip flexion. D. Maintain DIP joint flexion while allowing full active PIP extension. Answer: C. Maintain PIP joint extension while allowing full active dip flexion. This question assesses understanding of conservative management for a boutonniere deformity, specifically the goal of splinting. The deformity involves a PIP flexion contracture and dip hyperextension, and the aim is to correct the PIP joint position. The primary focus of splinting is to maintain the PIP joint in full extension to prevent further shortening of the central slip, while leaving the dip joint free to allow for active flexion exercises to address extensor tendon tightness at that joint. For example, a custom-molded orthosis or a prefabricated ring splint might be used to block PIP flexion. Remember, the core strategy for boutonniere deformity correction is to restore PIP extension while keeping the dip mobile. Question 5. A 60-year-old patient presents with a progressive flexion contracture of the ring finger and small finger, with palpable cords in the palm. The patient denies pain. What is the most likely diagnosis? A. Trigger finger. B. Dupuytren's contracture. C. Flexor tenosynovitis. D. Carpal tunnel syndrome. Answer: B. Dupuytren's contracture. This question describes the classic presentation of Dupuytren's contracture, a common condition affecting the palmar fascia. Key clues include progressive flexion contracture of the ring finger and small finger, palpable cords in the palm, and denies pain. Dupuytren's involves thickening and shortening of the palmar fascia, leading to fixed flexion deformities of the digits, most commonly the ring and small fingers, and is typically painless. For instance, a patient might notice difficulty fully extending their fingers to place their hand flat on a table. The combination of painless, progressive flexion contractures and palpable cords in the palm strongly points towards Dupuytren's. Question 6. A patient with a complete low radial nerve laceration at the distal forearm would most likely present with which of the following deficits? A. Weakness in wrist flexion and ulnar deviation. B. Inability to extend the thumb and fingers at the MCP joints. C. Sensory loss over the entire palmar aspect of the hand. D. Weakness in shoulder abduction. Answer: B. Inability to extend the thumb and fingers at the MCP joints. This question tests knowledge of radial nerve anatomy and its motor innervation. A complete low radial nerve laceration at the distal forearm implies that the nerve is injured after it has given off branches to the wrist extensors but before innervating the more distal extensors. The primary motor function affected by this specific injury level would be the innervation to the extensor digitorum communis, extensor pollicis longus and brevis, and extensor indicis proprius, leading to an inability to extend the thumb and fingers at the MCP joints. An example would be a drop finger or drop thumb presentation, where the patient cannot actively lift their fingers or thumb at the knuckles. Remembering the radial nerve's role in finger and thumb extension is crucial for understanding its functional impact. Question 7. A 32-year-old typist reports aching pain and tenderness over the lateral epicondyle, exacerbated by gripping and resisted wrist extension. Which of the following special tests would most likely be positive? A. Tinel's sign at the elbow. B. Phelan's test. C. Cousin's test. D. Finkelstein's test. Answer: C. Cousin's test. This question describes symptoms consistent with lateral epicondylitis, often known as tennis elbow. The keywords are aching pain and tenderness over the lateral epicondyle, exacerbated by gripping and resisted wrist extension, which pinpoint the affected area and actions. Cousins' test, which involves resisted wrist extension with the elbow extended and forearm pronated, specifically provokes pain at the lateral epicondyle, indicating inflammation or degeneration of the common extensor origin, making it the most appropriate test. For example, a patient performing Cousins' test would experience sharp pain at their outer elbow as the therapist resists their wrist movement. Understanding the specific provocative tests for common conditions like lateral epicondylitis is essential for accurate diagnosis. Question 8. A patient has undergone a Zone 2 flexor digitorum profundus tendon repair to the small finger. During initial rehabilitation, which of the following is the most important instruction regarding active range of motion? A. Actively extend the small finger to the limits of pain. B. Actively flex the small finger only to the amount of passive flexion. C. Avoid active flexion at the dip joint of the small finger. D. Perform full active flexion and extension to prevent stiffness. Answer: C. Avoid active flexion at the dip joint of the small finger. This question focuses on protecting a flexor tendon repair, specifically in Zone 2, no man's land, which is prone to rupture. The critical instruction, avoid active flexion at the dip joint of the small finger, is paramount during the initial phases of rehabilitation after a flexor digitorum profundus (FDP) repair. Active DIP flexion places high tensile forces on the repaired FDP tendon, risking rupture before adequate healing has occurred. For instance, a therapist might instruct the patient to only perform passive flexion or specific controlled active glides within a protective orthosis to ensure the repair remains intact. Protecting the delicate tendon repair is the top priority in the early postoperative period. Question 9. A patient presents with acute onset of severe, burning pain, swelling, and trophic changes in the hand following a distal radius fracture. The pain is disproportionate to the injury. Which condition should the therapist immediately suspect? A. De Quervain's tenosynovitis. B. Complex regional pain syndrome, CRPS. C. Carpal tunnel syndrome. D. Radial nerve palsy. Answer: B. Complex regional pain syndrome, CRPS. This question describes the classic symptoms of complex regional pain syndrome, CRPS, a challenging condition. The keywords acute onset of severe, burning pain, disproportionate to the injury, swelling, and trophic changes, like skin changes, hair changes, or nail changes, are all hallmarks of CRPS, often triggered by trauma such as a fracture. CRPS involves an abnormal response of the nervous system, leading to amplified pain and autonomic dysfunction. For example, the patient might experience severe hypersensitivity to light touch that is far greater than expected for a simple fracture. Recognizing these distinct signs quickly is crucial for early intervention, which is key to managing CRPS effectively. Question 10. A client with a mallet finger injury presents with a persistent extensor lag at the dip joint after conservative treatment. What is the most appropriate next step in intervention? A. Begin passive range of motion into extension. B. Reevaluate splint adherence and re-educate on proper splint wear. C. Initiate aggressive active range of motion into flexion and extension. D. Discontinue splinting and refer for surgical consultation. Answer: B. Reevaluate splint adherence and re-educate on proper splint wear. This question addresses the management of a persistent extensor lag in a mallet finger, a common issue when conservative treatment fails. The keyword persistent extensor lag after conservative treatment suggests that the splinting protocol may not have been strictly followed. Mallet finger conservative treatment relies on continuous dip joint immobilization in full extension for a specified period, typically 6 to 8 weeks, followed by night splinting, and any flexion during this period can compromise healing. Therefore, Before considering more invasive options, it is crucial to re-evaluate the patient's adherence to the splinting protocol and provide thorough re-education on consistent wear. This ensures the foundational conservative approach has been fully optimized before escalating treatment. Question 11. Which of the following physical agent modalities is contraindicated for a patient with an acute inflammatory condition like a flare-up of rheumatoid arthritis in the wrist? A. Paraffin wax. B. Ice pack. C. Fluidotherapy. D. Ultrasound, thermal setting. Answer: D. Ultrasound, thermal setting. This question assesses knowledge of contraindications for physical agent modalities, particularly in the context of acute inflammation. The key phrase acute inflammatory condition and flare-up of rheumatoid arthritis points to a need to avoid modalities that increase heat, which can exacerbate inflammation and pain. Thermal ultrasound, paraffin wax, and fluidotherapy all deliver heat, which is generally contraindicated during acute inflammation. An ice pack, conversely, is indicated for acute inflammation to reduce pain and swelling. Always remember that heat modalities are generally contraindicated in acute inflammatory phases, as they can worsen the condition by increasing blood flow and metabolic rate. Question 12. A patient presents with a progressive decrease in thumb palmar abduction and opposition, along with pain at the base of the thumb during pinch activities. What type of orthosis is most commonly prescribed to manage this condition conservatively? A. Volar wrist cock-up splint. B. Resting hand splint. C. Thumb spica splint, CMC joint immobilization. D. Dynamic PIP extension splint. Answer: C. Thumb spica splint, CMC joint immobilization. This question describes symptoms consistent with thumb carpal, CMC, joint osteoarthritis, a common condition. The key clues are progressive decrease in thumb palmar abduction and opposition and pain at the base of the thumb during pinch activities, which are classic signs of CMC joint degeneration. A thumb spica splint that immobilizes or supports the CMC joint is the most commonly prescribed conservative orthosis to reduce pain by providing rest and stability to the arthritic joint. For instance, a custom-molded thermoplastic splint can be fabricated to encompass the thumb and wrist, offloading the stressed CMC joint. Stabilizing the thumb CMC joint is a primary conservative strategy to manage pain and improve function in CMC arthritis. Question 13. A patient demonstrates limited PIP joint flexion contracture, example 20 degrees, after a hand injury. Which intervention is most appropriate to address this stiffness and improve range of motion? A. Static progressive splinting into extension. B. Immediate forceful passive stretching. C. Continuous passive motion machine at maximal force. D. Short arc active motion exercises only. Answer: A. Static progressive splinting into extension. This question addresses a common post-injury complication, a PIP joint flexion contracture, and asks for the most appropriate intervention. The phrase limited PIP joint flexion contracture indicates a need to improve extension. Static progressive splinting involves applying a low load, prolonged stretch to the stiff joint to encourage tissue elongation and increase range of motion into extension. For example, a custom fabricated splint can be incrementally adjusted by the therapist to apply increasing tension over time, gently stretching the tight joint. Forceful passive stretching or maximal force continuous passive motion can be harmful, and short arc active motion alone may not provide sufficient stretch for contracture release. Question 14. A 28-year-old patient sustained a dorsal dislocation of the PIP joint. After reduction, the joint is stable. What is the most appropriate initial splinting position to protect the joint? A. PIP joint in 0 to 10 degrees of flexion. B. PIP joint in 45 degrees of flexion. C. PIP joint in full extension. D. PIP joint in 90 degrees of flexion. Answer: A. PIP joint in 0 to 10 degrees of flexion. This question tests knowledge of immediate post-reduction management for a dorsal PIP joint dislocation. The key phrase dorsal dislocation of the PIP joint implies injury to the volar plate, which prevents hyperextension. After reduction and confirmation of stability, the most appropriate initial splinting position is 0 to 10 degrees of flexion to provide slight slack to the healing volar plate and prevent re-injury or chronic hyperextension, while allowing for early protected motion. For example, a dorsal block splint might be used to block full extension, allowing controlled flexion. This position protects the healing volar plate and collateral ligaments while initiating a safe rehabilitation process. Question 15. A client presents with a firm, immobile, non-tender lump on the dorsal aspect of the wrist. The client reports it fluctuates in size but causes no pain or functional limitations. What is the most likely diagnosis? A. Lipoma. B. Rheumatoid nodule. C. Ganglion cyst. D. Giant cell tumor of tendon sheath. Answer: C. Ganglion cyst. This question describes the classic presentation of a ganglion cyst, a very common mass in the hand and wrist. Key descriptors are firm, immobile, non-tender lump on the dorsal aspect of the wrist, and fluctuates in size but causes no pain or functional limitations. Ganglion cysts are benign, fluid-filled sacs that typically arise from a joint capsule or tendon sheath, often on the dorsal wrist, and their size can change. For example, a patient might notice the lump becoming smaller when they rest their wrist and larger with increased activity. The characteristic painless, fluctuating dorsal wrist lump is highly indicative of a ganglion cyst. Question 16. During a sensory evaluation, a therapist performs a 2-point discrimination test. Which of the following indicates normal sensibility? A. Distinguishing 5 mm apart. B. Distinguishing 10 mm apart. C. Distinguishing 15 mm apart. D. Distinguishing 2 mm apart. Answer: D. Distinguishing 2 mm apart. This question assesses knowledge of normal values for 2-point discrimination, a common test for assessing nerve function and sensory integrity. Normal sensibility is indicated by the ability to distinguish two separate points when they are 2 to 5 mm apart. However, 2 mm is often considered the threshold for normal static 2-point discrimination in the fingertips. For example, when applying 2 points with a discriminator tool to the fingertip, a person with intact sensation would report feeling 2 distinct points at 2 mm. The finer the discrimination, the better the nerve innervation and sensory perception. Question 17. A patient sustained a high ulnar nerve injury. What is the most appropriate splinting intervention to prevent overstretching of the denervated muscles and improve pinch strength? A. Wrist cock-up splint. B. Resting hand splint with fingers in extension. C. Anti-claw splint, MCP flexion block. D. Thumb spica splint. Answer: C. Anti-claw splint, MCP flexion block. This question focuses on managing a high ulnar nerve injury, which typically results in a claw-hand deformity due to weakness of the intrinsic muscles, interossei and 2 ulnar lumbricals. The goal of an anti-claw splint, specifically an MCP flexion block splint, is to prevent hyperextension at the MCP joints and subsequent overstretching of the denervated intrinsic muscles, while allowing the extrinsic extensors to effectively extend the interphalangeal joints. For example, a patient might wear a splint that holds their 4th and 5th MCP joints in slight flexion, which aligns the digits for improved grasp and pinch without allowing hyperextension. This splint directly addresses the characteristic deformity and functional deficits of ulnar nerve palsy. Question 18. A client has sustained significant full-thickness burns to the dorsum of the hand. What is the primary purpose of prescribing pressure garments during the rehabilitation phase? A. To increase skin elasticity and reduce joint stiffness. B. To reduce edema and promote scar maturation. C. To prevent infection and promote wound closure. D. To improve sensation and nerve regeneration. Answer: B. To reduce edema and promote scar maturation. This question relates to burn management and the critical role of pressure garments. The primary purpose of applying pressure garments after burn injuries, especially full-thickness burns, is to reduce edema and, most importantly, to promote scar maturation by controlling collagen deposition and organization, thus preventing hypertrophic and keloid scarring. For example, a custom-fitted glove that applies continuous, even pressure over the burned area helps to flatten and soften the developing scar, improving its appearance and pliability. Pressure therapy is a cornerstone of burn rehabilitation, aimed at optimizing scar quality and preventing contractures. Question 19. Which of the following conditions typically presents with night pain, particularly affecting the thumb, index, and middle fingers, and is exacerbated by sustained wrist flexion? A. De Quervain's tenosynovitis. B. Cubital tunnel syndrome. C. Carpal tunnel syndrome. D. Guyan's canal syndrome. Answer: C. Carpal tunnel syndrome. This question describes the classic symptoms of carpal tunnel syndrome, CTS, one of the most common nerve entrapment neuropathies. The key indicators are night pain, affecting the thumb, index, and middle fingers, radial 3.5 digits, and exacerbated by sustained wrist flexion. These symptoms are due to compression of the median nerve within the carpal tunnel. For example, a patient might report waking up with numb fingers or pain after sleeping with their wrists flexed. Recognizing this specific cluster of symptoms is fundamental for diagnosing and managing carpal tunnel syndrome. Question 20. A patient reports increased pain and tingling in the ring and small fingers, especially when holding a phone or leaning on their elbow. Tinel's sign is positive at the elbow. Which nerve is most likely compressed? A. Radial nerve. B. Median nerve. C. Ulnar nerve. D. Axillary nerve. Answer: C. Ulnar nerve. This question describes symptoms consistent with ulnar nerve compression, specifically at the cubital tunnel. The crucial clues are increased pain and tingling in the ring and small fingers, which are innervated by the ulnar nerve, and exacerbation when holding a phone or leaning on their elbow, which places direct pressure on the nerve at the cubital tunnel. A positive Tinel sign at the elbow further confirms ulnar nerve involvement. For example, a patient might experience sudden shooting pain or numbness in their little finger when their elbow is bent for prolonged periods. Understanding the ulnar nerve's distribution and common compression sites is essential for diagnosis. Question 21. A patient presents with a scaphoid fracture confirmed by X-ray. What is a significant risk of this type of fracture due to its unique blood supply? A. Compartment syndrome. B. Avascular necrosis. C. Heterotopic ossification. D. Reflex sympathetic dystrophy. Answer: B. Avascular necrosis. This question highlights a critical complication associated with scaphoid fractures. The keyword scaphoid fracture immediately brings to mind its notorious susceptibility to avascular necrosis, AVN. The scaphoid bone has a retrograde, distal to proximal, blood supply, meaning blood enters the bone from its distal pole and flows proximally. A fracture across its waist can disrupt this delicate blood supply to the proximal pole, leading to bone death, avascular necrosis, due to lack of nourishment. For example, if the blood supply is compromised, the bone fragment may not heal properly and can collapse. Understanding this unique vascular characteristic is crucial for appropriate treatment and patient education regarding potential complications. Question 22. A client is performing nerve gliding exercises. What is the primary purpose of these exercises in hand therapy? A. To increase muscle strength. B. To reduce joint stiffness. C. To improve nerve mobility and reduce adhesions. D. To desensitize hypersensitive areas. Answer: C. To improve nerve mobility and reduce adhesions. This question directly tests the understanding of nerve gliding exercises. The primary purpose of nerve gliding, also known as nerve flossing, is to improve the mobility of a peripheral nerve relative to its surrounding tissues, reducing adhesions or compression that may be causing pain, numbness, or weakness. These exercises involve specific movements that cause the nerve to slide and glide through its pathway, preventing it from becoming stuck. For instance, a median nerve glide might involve wrist and finger extension combined with shoulder abduction to encourage the nerve to move freely. Nerve gliding is essential for addressing nerve entrapment or adherence following injury or surgery. Question 23. A patient with a severe flexion contracture of the PIP joint has been prescribed a dynamic extension splint. What is the main principle behind this type of splinting? A. To provide rigid immobilization of the joint. B. To apply a constant, low-load stretch to increase range of motion. C. To facilitate active muscle contraction against resistance. D. To prevent further flexion deformity. Answer: B. To apply a constant, low-load stretch to increase range of motion. This question focuses on dynamic splinting, specifically for a flexion contracture. The key phrase, dynamic extension splint, implies movement, and the main principle of dynamic splinting is to apply a constant, low-load, prolonged stretch to improve passive range of motion. These splints use springs, elastic components, or rubber bands to create a gentle, continuous force that helps elongate shortened tissues. For example, a dynamic splint might have a spring-loaded outrigger that continuously pulls a finger into extension, gradually improving the contracture. The constant low-load stretch promotes tissue remodeling and plastic deformation, gradually restoring joint mobility. Question 24. A patient post-flexor tendon repair is demonstrating difficulty with isolated muscle control and joint awareness. Which sensory re-education technique would be most appropriate initially to enhance proprioception? A. Tuning fork vibration. B. Texture discrimination. C. Mirror therapy. D. Localization/constant touch. Answer: C. Mirror therapy. This question addresses sensory re-education, specifically aiming to enhance proprioception and body awareness after an injury, like a flexor tendon repair. Mirror therapy is an excellent initial technique for improving proprioception and motor control, especially when isolated muscle control and joint awareness are issues. By watching the uninvolved hand move in the mirror, the brain receives visual feedback that can help remap and improve the motor and sensory control of the involved hand. While other options address sensory deficits, mirror therapy directly addresses proprioceptive input and brain-body connection in a unique way that can be very beneficial for motor relearning. Question 25. A therapist is educating a patient on appropriate lifting techniques to prevent re-injury after a wrist sprain. Which recommendation is most appropriate? A. Lift heavy objects with a pronated forearm grip. B. Use two hands and lift with the palms up, avoiding wrist deviation. C. Maximize wrist extension during lifting to provide stability. D. Lift with the elbow extended and minimal trunk rotation. Answer: B. Use two hands and lift with the palms up, avoiding wrist deviation. This question focuses on ergonomic principles and injury prevention, particularly after a wrist sprain. To protect the wrist, it is most appropriate to use two hands for lifting and to maintain a neutral wrist position, avoiding excessive wrist deviation, radial or ulnar, and extreme wrist flexion or extension. Lifting with palms up, supination, helps engage stronger arm and shoulder muscles and minimizes wrist strain. For example, when lifting a box, the patient should use both hands, keep the wrist straight, and lift with their legs, not their back or wrists. Proper body mechanics, especially maintaining neutral wrist alignment and distributing the load, is key to preventing re-injury.